Revision, total hip replacement surgery. Indication, osteolysis, infection, instability, fracture. Goal is remove the implant and the cement, reconstruct the bone, stable hip, restoration of center of rotation. Special instruments, Oscar, ultrasonic cement removal, curve stable rouges, renovation, explant acetabular cup removal system, acetabular cup forceps, flexible, straight and curved revision osteotomes and burrs, cerclage wires, impaction graft, and Dahl Miles cable with crimper, crimp, tensioner, and cable passer. X-ray, Jude views to assess the column, CT scan, delineate anatomy, acetabulum, look for protrusion and superior migration, get angiogram if in doubt. Classification, AOS classification, acetabular classification, segmental, cavitatory, combined, pelvic disc continuity, and chylosis. Acetabulum AOS femoral classification, segmental, cavitatory, combined, malalignment, stenosis, femoral discontinuity. Regarding acetabulum side, segmental defect. I will try to create and reconstruct segmental defect in if the rim is incompetent and less than 2.3 of its remain, I need to have structural allograft and reconstructive anti-protrusive cage to make a foundation. If more than 2/3 of the rim is competent, I need a hemispherical porous coated cup augmented with trabecular metals, which is made by tritanium and metal augments. If I am planning to use the allograft, I want to reconstruct and convert the structural deformity into a cavitatory and then do impaction bone grafting. So less than 2/3 incompetent, structural allograft plus reconstructive anti-protrusive cage, more than 2/3 hemispherical porous coated cup augments with screws. In a cavitatory, it's a volume loss. I need to define it. It's a peripheral or central. I will use Morselli's impaction graft and then reverse the reamer. Combined, if combined, use trabecular metal cup as a replacement to the allograft. Doesn't have to be in anatomical position. Cup fixed into the ischium and acetabulum cup cemented independent of the position of the cage. Pelvic discontinuity, I will check the neurovascular assessment. I will put reconstruction plate, anti-protrusive reinforcement cage, Schneider cage, and custom triflange acetabular components. Regarding the femoral defects, if segmental deficient supporting shell of the femur is there, cavitatory, loss of endosteal blood supply, blood intact loss of endosteal bone and with intact cortex, I will use Morselli's fresh fusion impaction compression bone graft. Malalignment, use of femoral geometry due to the surgery, stenosis from trauma or bone hypertrophy, and femoral discontinuity. Regarding Paprosky classification of femoral defect, type 1 is sufficient proximal bone support, primary stem using double wedge taper design with a proximal fitting. If compromised rotation stability, fully porous stem should be used. Type 2, insufficient metaphyseal bone stock. Implant should have diaphyseal coating for ingrowth. 3A, more than 4 cm of diaphyseal bone stock is available, require diaphyseal fixation. Extensive coated, porous coated cylindrical stem. Type B, less than 4 cm of the diaphysis, need a modular stem design. Type 4, no supporting diaphysis available, require total femoral replacement. Regarding cemented, I can use cement in cement with downsizing the stem if bone cement interface is good. Must be aseptic. In case of uncemented, I can use extensively porous coated implant. Stem achieve wedges, press fit for axial stability. Some of the implants revision uncemented S-ROM TPI synthesis. Can add prophylactic cerclage wires, multiple osteotomy to liver out.